Anya Jastreboff, Darren McGuire, Mike Gibson coming to you live for This Week in Obesity. A lot of talk about, do we really need to hit 25% weight reduction? Is 20% enough? Talk to us about the right weight reduction for the right patient. Where are we with that? Anya?
Yeah, I mean, I think it depends on the patient and what they need. Not every patient needs to lose 20% or 25%. Some patients would really benefit from 10% or 15%. We do see downstream diseases, meaning obesity related diseases, really being impacted around that 15%. So that keeps on coming up over and over again. But again, not everybody would benefit from that necessarily. So I think we have to look at the individual patient, what what their obesity is at that stage, and also what obesity related diseases they may have or what risk they may have for developing those obesity related diseases. I also think we have to think about this in the context of the patient's age. So a younger patient versus an older patient and what the risks versus benefits are. So not everything about weight reduction is positive, right? We know that with bariatric surgery, there is bone loss. With any form of obesity treatment that we have today, there is also muscle loss along with fat mass loss, which is not necessarily a negative thing, right? Because people with obesity they have more lean mass. So that's not necessarily a negative thing. We just have to take that into account. What age is the person and how will that impact their function, their daily function? So we have to think about bone, we have to think about muscle, and we have to take all that into consideration. But I don't think there's one right weight reduction percent body weight reduction amount for every patient.
Yeah, and
Darren?
I'll just add on to that. At least as far as I know, the FDA is still requiring a minimum on average 5% weight loss.
Yeah.
Now, I think that probably needs to change. And I give a talk on obesity drugs and development, and I've thought I was pioneering proposing that we set the regulatory standard at least to 10% now that we have so many agents hitting that. Whether it needs to be 20% or higher, I totally agree with Anya. A couple of reasons. One is patients are different and they need different weight reductions, but also it's inevitable that these agents that are in development, we're targeting so many multiple parallel pathways that they're going to be complementary at some level. And to have therapeutic options where we can mix and match for the individual what gets them to their best weight target. So combining three agents that are reasonably affordable that each give 8 or 10%, you're going to reproduce maybe something like retatrutide that does it all in one therapeutic. And so I think just to have a toolbox is going to be awesome. And as we march forward, where we're having a minimum cardiovascular safety, and what we're seeing now is the efficacy outcomes, and it's just a whole new domain. I think we're here with obesity where we were with diabetes a decade ago, and it's just a bright future. And I don't know, Anya, if you know, the last I counted, I think there are 59 compounds in phase one or beyond for the treatment of overweight and obesity. And it is just exploding in the field and all different mechanisms, many of which we've never heard of. So, um,
I would say there's over 100. I mean, there are so many, and it's not just so we're focusing in on talking about the nutrient stimulated hormone based therapies, so GLP-1, GIP, amylin, glucagon. But there are many others, right? There are many other mechanisms being explored, as you said. So there's myostatin activin pathway inhibitors that are being looked at for preservation of lean mass while maximizing fat loss. And the question with those is, would those reach a 5% weight reduction threshold? But if you're markedly improving body composition, the next step is, well, let's look at function, right? How are we actually functioning in terms of the muscle that we have? And that'll be the important question to answer. But those are just, two sets of mechanisms that are being looked at, and there are many other mechanisms that are being explored. I think just right now, what we're focused on are the nutrient stimulated hormone based therapies because they're leading the charge.
Can I ask you is there a two-phase solution here? I mean, you have an induction phase with that big weight loss at first. Then you kind of have a maintenance phase. Do you foresee a world where we'll have one drug for induction and one drug for maintenance?
I mean, I think it's an interesting question. I do get asked this quite a bit. I don't think we know the answer yet. If we make the assumption that obesity is similar to other chronic diseases, then the question is, if someone responds to an ACE inhibitor and a diuretic, would you switch them to a beta blocker, right? So the question is, would that be the case for obesity treatment? That it would be different. It may be. I don't know. I don't think we know the answer to that. I think that if a particular mechanism works for a patient's specific type of obesity, then it would make sense that that mechanism in some way would help them maintain that weight reduction. But I think we need longer term studies, and we need real world data to actually see what's going on. Clinically, it varies from patient to patient. Most patients, if you keep them on the medicine, they maintain weight, but there's disease progression. So some patients start to trend up, other patients totally stay at the weight that they are at that dose. And other patients, and this is maybe the smallest bucket, but other patients, there are patients who stay on the dose and then slowly, slowly over time, they keep on losing little amounts of weight. And I don't know why. And we, again, it speaks to the different types of obesities, and we really don't know. So for those patients, I tend to space out the dose, right? So they don't have to take it, or I decrease the dose. So it just depends on the patient. So I think we don't know enough yet about obesity and about the different types of obesities to know whether it will be more similar to other chronic diseases or whether we have some good reason to think that it would be different.
Aaron, thoughts?
No, I completely agree. These drugs work when you take them. I like Anya. I'm not as concerned with the muscle mass loss, or it's not just muscle; it's lean mass. So it's also skeletal bone but this is adaptive at some level. Like, we don't get worried when the LVH regresses when we treat the blood pressure. It's adaptive back to physiology, and so the question becomes: will people? I think the two big questions is, will people continue to become more and more sarcopenic, in which case the myostatin activin inhibitors will come into play. I'm not sure that's what we need to be chasing right now, but also, to Anya's point, if people continue to lose weight and mass, what if they come off the medicine and they regain the weight? Will they recover their lean mass accordingly? When we have an experience of this, when we put people into microgravity exposure in orbit, within 2 or 3 weeks, they're completely remodeled, right? And so when they get back on Earth, they can hardly stand up, but it takes 2 or 3 weeks and they've adapted back to get their muscle mass in there. So, it's a very dynamic situation with the skeletal system and also with the muscles. So, but we do need to continue to study it. We have to figure out some way to scale or index to anthropometrics. What is the right amount of muscle for any given weight? And are we getting below that target with these medications? I think we're probably not. Now, there are people I get concerned about, the really elderly, frail patients, the dialysis patients, people have underlying sarcopenic conditions. Probably not the best drug for those people, but that's a pretty small population compared with the eligible folks with these drugs.
Yeah,
Right.
and I agree, and I think that one of the things to consider is looking a bit at the bariatric surgery literature, because again, as we get to higher efficacy or combinations, as Darren was saying, and that is what we need to do, is we need to use different mechanisms and combinations of these medicines, as long as they're not overlapping mechanisms, just like we do for diabetes or hypertension or anything else. But as we get to higher degrees of weight reduction, we should look at what were we looking at in bariatric surgery. So there is bone loss. And is that related to the weight reduction itself? There is some component, obviously, of malabsorption or changes in absorption in terms of bariatric surgery, but really, the weight reduction is fairly rapid with bariatric surgery. With these medicines, we actually can slow down the weight reduction. So we need to do studies to look at, well, what is the impact of the speed of the weight reduction? Are people able to for example, slow down the titration, one, to decrease side effects if they're occurring, two, to enable people to take in the nutrients, three, to make sure they have energy to exercise, to do that resistance exercise to maintain the good quality muscle mass. So I think there's so many questions to ask that with bariatric surgery, we didn't have the luxury to slow down the weight reduction. You got what you got. With these medicines, we can actually really tailor even the rate of weight reduction, and we have no information about that. And so that's another really interesting question.
Haven't even thought about that. That's a great point. A great differentiator between those two different ways of losing weight. Again, I always learned something from you too. Thanks for joining us, and thanks to all of you for joining us here for This Week in Obesity.